Here we have a case of a lumbosacral spine MRI in 40-year-old female. So what we have got is abnormality at T11-12 level. On T1, T2 and stir sequence, what we see is disc dehydration, annular fissuring, and a broad-based central posterior disc protrusion, which is much better appreciated on the axial sequence. On the axial sequence, the CSF is all effaced and there is moderate cord compression, which is much better appreciated on the axial sequence compared to the sagittal sequences. On the sagittal T2 and stir sequence, you can see abnormal signal within the spinal cord, which is extending vertically from above downwards for approximately 2 centimeters at the level of the disc protrusion. This finding is typical for compressive myelopathy. The way to describe this abnormality in reporting is there is annular fissuring and broad-based central posterior disc protrusion at T11-12 level, effacing the anterior and posterior CSF spaces completely, resulting in moderate cord compression and significant abnormal signal within the spinal cord. Compared to the spinal cord above and below, there is loss of volume of the spinal cord, suggestive of mild to moderate spinal cord atrophy. Hence, this is likely to be long standing. What to do with these patients? If the patient is coming from primary care, we need to tell this patient needs to be assessed for any symptoms and signs of cardiac venous syndrome. If present, the patient needs to be referred to emergency department urgently. If not, the patient needs to be referred to the spinal surgical team urgently on outpatient basis.